Well, you said you wanted to have your feet held to the fire. Put up the little flames in the air. Good morning. I convene this hearing of the Subcommittee on Oversight and Investigations. We're here again today to discuss an ongoing problem with our entitlement programs, waste, fraud, and abuse. This time in the Medicare Part D program. However, the failures that we will hear about today go far beyond lost dollars and cents. Rather, they are helping to feed the prescription drug abuse crisis that is gripping the country. Medicare Part D is the fastest growing component of the Medicare program, providing approximately 39 million beneficiaries with supplemental prescription drug coverage. Given this rapid growth, Medicare Part D has been a prime target for fraud and abuse. In fact, this past June, the Department of Justice announced a nationwide Medicare fraud takedown, which led to charges against 243 individuals for approximately $712 million in false billings. More than 44 of the defendants were arrested on fraud related to Medicare Part D. This joint law enforcement effort, which involved the Department of Justice, the Department of Health and Human Services, the Office of Inspector General, and the FBI, should be commended. But more work needs to be done at the agency level to ensure that fraudsters are not able to take advantage of the program in the first place. Thankfully, since the inception of the Part D program, the Office of Inspector General has been working diligently to reduce waste, fraud, and abuse in the program. The OIG has released numerous reports and issued several recommendations intended to strengthen the integrity of Medicare Part D, which would save taxpayers a tremendous amount of money and would ensure that prescription drugs are being used as intended and not overprescribed or diverted. Unfortunately, CMS has not implemented these recommendations. In its portfolio, the OIG highlighted at least 9 recommendations that CMS has not implemented. All of these recommendations were issued to CMS in at least one previous OIG report, and in some instances up to 5 previous reports that date back to December 2006. And these are common sense recommendations. For example, requiring plan sponsors to report all potential fraud abuse to CMS or the Medicare Drug Integrity Contractor. This recommendation was issued in 5 different OIG reports. Another important recommendation was to implement an edit to reject prescriptions written by providers who have been excluded from the Medicare program. That makes sense. Yet CMS hasn't taken any action to implement these recommendations. And just 6 weeks ago, one of today's witnesses, Dr. Agarwal, testified before this subcommittee and said, holding our feet to the fire is appropriate. And when asked about fraud occurring under CMS's watch, and as I said, that's precisely what we're going to be doing today. CMS's failure to implement these recommendations has led to trends of questionable billing associated with pharmacies, prescribers, and beneficiaries. In fact, in its data brief, which analyzed prescription drug events, OIG found that a lot of questionable billing was tied to commonly abused opioids. This subcommittee has held a series of hearings examining the growing problem of prescription drugs and heroin addiction that we know is ravaging our country. The opioid abuse epidemic resulted in a loss of 43,000 lives last year, and the problem continues to get worse. As we examine the Medicare Part D program, it troubles me that between 2006 and 2014, the total number of beneficiaries receiving commonly abused opioids grew by 92%, compared to 68% for all drugs. Similarly, the average number of prescriptions for commonly abused opioids per beneficiary grew by 20%, compared to 3% for all drugs. Since 2006, Medicare spending for commonly abused opioids has grown faster than spending for all Part D drugs. We need to take a close look at those numbers and make sure that this program is not contributing to this devastating epidemic. The OIG has outlined several common sense recommendations that CMS can implement. Now it's incumbent upon CMS to take action and actually prevent fraud and abuse before it reaches a level that requires a nationwide takedown. The committee is concerned that it continues to hold hearings like this one today, where we see steps not taken and tools not utilized to protect the integrity of these programs as well as taxpayers' dollars. Now, we acknowledge it is the people who are committing fraud, whether they're physicians or pharmacists or other people, they're the ones we're going after. But we are listening today to the ideas of Dr. Agarwal and Ms. Maxwell of how we can do that. So I thank our witnesses for joining us. You have the ability to save the American taxpayer massive amounts of money and, of course, save lives in this process. It is this subcommittee's hope that we will hear concrete plans from you on how we can go about accomplishing this task. I might say we need funds in other areas of care And so we'd also like to hear, when you make recommendations, if there are some things that actually save us money that we know we need. So, for example, in the mental health sphere, please tell us that as well. So thank you for being here today, and I now recognize the ranking member of the subcommittee, Ms. DeGette of Colorado, for 5 minutes.
Thank you so much, Mr. Chairman. Medicare Part D represents the fastest growing component of the Medicare program overall. From 2006 to 2014, spending for Part D drugs increased by 136%, from $51.3 billion to $121 billion. In the last 5 years, the OIG has reported a 134% increase in complaints and cases involving the Part D program. The Office of Management and Budget has declared Medicare Part D a high-error program with an estimated improper payment rate of 3.3%, or $1.9 billion. That could make up the difference with the 21st century cures and the money we had to take out. P.S. As with all federal health care programs, reducing improper payments and protecting taxpayer dollars must be a priority of the department and a priority of this committee. But here's the part where I pile on to the chairman's statement, because it's not just about federal taxpayer dollars. It's about all of the other problems you have with Medicare Part D. As the chairman said, we're in the midst of a prescription drug abuse crisis. In 2013, prescription painkillers were involved in over 16,000 overdose deaths, and heroin was involved in an additional 8,200 deaths. Over 2.1 million Americans live with a prescription opioid addiction, while 467,000 Americans are addicted to heroin. These are absolutely devastating numbers, and the chairman is right. This series of hearings that we've had this year has been, I think, one of the most eye-opening series of hearings that we've ever had in this committee, illuminating this problem. And Part D is a part of it because drug diversion and overprescribing are serious challenges in the program. Between 2006 and 2014, Part D spending for commonly abused opioids grew by 156%, which outpaced the growth of spending for all Part D drugs. Additionally, generic Vicodin was the #1 prescribed drug in the Part D program in 2013. The OIG is going to testify that investigations into Part D fraud, waste, and abuse have uncovered not only financial harm to the program, but also serious medical harm to individual patients from the inappropriate prescribing and diversion of opioids, as well as other prescription drugs. Complex criminal networks involving healthcare professionals, pharmacies, and street traffickers are becoming a pervasive element of Part D fraud schemes. In fact, last month, the department announced the largest takedown in the history of the Medicare fraud strike force, resulting in charges against 243 individuals involving about $712 million in false billings. More than 44 of the defendants arrested were charged with fraud related to Part D. So I want to take a minute to recognize both the OIG and CMS for the excellent work in achieving this important outcome and sending a message to the perpetrators that those who steal from federal health care programs will pay a high price for their crimes. I look forward to hearing from Dr. Agrawal, our perennial witness to this committee now, about what the agency has done to strengthen program integrity in Part D, particularly as it pertains to the issue of drug diversion and overprescribing. I know that the agency's overutilization monitoring system has already resulted in a substantial reduction in the number of opioid overutilizers in Part D, and I think this is an excellent step in the federal effort to address the prescription drug abuse epidemic. However, as we're going to hear from OIG today, Part D remains vulnerable to fraud, and there are additional opportunities to identify fraud, waste, and abuse. As the OIG describes, ensuring the integrity of the Part D program requires constant and proactive efforts at every level, from the plan sponsors to CMS program integrity contractors to the oversight role. However, CMS does not require plan sponsors to report potential fraud and abuse. In 2012, only 35% of plans reported such data voluntarily. In the opinion of the OIG, The low level of fraud identified by some plan sponsors raises questions about the sufficiency of their fraud and abuse detection programs. I know, Dr. Agarwal, you'll have more to tell us about this today. I think it's important, Mr. Chairman, that we follow up with the plan sponsors themselves to find out why they're not reporting this information about the fraud detection system. It would have been helpful to have them here today, but perhaps we could have another hearing. And with that, I yield back. Thanks.
Gentlelady yields back. I now recognize the Vice Chair of the full committee, Ms. Blackfern, for 5 minutes.
Thank you, Mr. Chairman. I want to say thank you to our witnesses. It's not your first appearance, and I'm certain it is not going to be your last. We are so pleased to dig into this issue. The Chairman spoke very well to that. And going back to what Ms. DeGette was saying, when you look at the opioids, you've got the abuse, the beneficiaries receiving these prescriptions grew by 92% in 8 years. Now, common sense is going to tell you something is wrong with that. I mean, that's just common sense. And then last month, we had 243 individuals charged with $712 million in false billings. These people were also charged with money laundering, aggravated identity theft, and what these crimes highlight and what this growth highlights is basically what's happening at CMS, Dr. Agarwal, which is the pay and chase model. And it is just not working. And my office has just completed a study going back and looking at the Inspector General reports. And I want you to know, HHS ranks as, I think it is number 4 over the past 10 years in collective abuse of federal, no, number 2. They're number 2 on the list. $10.3 billion wasted. OIG has pinpointed this. And you have good suggestions. You've got 9 outstanding recommendations made for CMS right now that you can do something about this, and it hasn't been implemented. Now, you're going to say, we need more money. Well, guess what? When you've got a budget that is closing in on $1 trillion and you've got $10.3 billion worth of waste that you've done nothing about, we need to come dock you that $10.3 billion. And by the way, that's just a 4-year window. You don't deserve more money. You don't deserve it because you're not taking good care of the taxpayer dollars that are coming your way. What we want is to make certain that people that need a program and deserve a program and are rightfully in a program are going to receive the benefits of that program, but waste, fraud, and abuse is going to be targeted and it is going to be rooted out. And when you are given recommendations, we expect those recommendations to see an action. And don't tell me you're overworked, and don't tell me you don't have enough money. Because when you've got a job to do, you work until the job is done. And that is what we are wanting to see, is that you are going to do your job. So my question to you today is going to be very pointed. You've been given recommendations. Do you agree with the recommendations? What are you doing to enact those recommendations, and what is your timeline for having them completed? And those are the questions I am going to have. Mr. Chairman, I will yield my time to whomever would like the balance of my time.
Is there anybody on this side who would like to speak on this? If not, the gentlelady's time, she yields back, and now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes.
Thank you, Mr. Chairman. The Medicare Part D program has been a great success for our nation's seniors and for people with disabilities, and I'm glad we're here today to discuss ways to strengthen and improve it. For decades before its enactment, seniors and disabled Americans, often living on fixed incomes, struggled to afford the rising cost of prescription drugs. Now more than 40 million Americans have access to affordable medications through the Medicare Part D program. And the ACA strengthened Part D and took crucial steps to improve affordability and access by closing the gap in coverage where beneficiaries pay the full cost of their prescriptions, known as the donut hole. Before the ACA, many beneficiaries struggled with crippling out-of-pocket costs in the coverage gap. The ACA gradually phases out the donut hole and closes it completely by 2020. Since the law's enactment, 9.4 million seniors and people with disabilities have saved over $15 billion on prescription drugs, an average of $1,598 per beneficiary. In 2014 alone, nearly 5.1 million seniors and people with disabilities saved $4.8 billion, or an average of $941 per beneficiary. And these are real dollars and real savings for Americans, allowing them to live healthier lives and have the peace of mind they won't have to decide between putting food on the table or paying for life-saving medications. In addition, the ACA strengthened Medicare by improving the solvency of the program and strengthening program integrity. Notably, the law moved beyond the traditional pay-and-chase model to a preventative approach that seeks to keep fraudulent suppliers out of the program before fraud, waste, and abuse occur. For example, under the authorities in the ACA, CMS recently issued a final regulation that requires all Part D prescribers to enroll in Medicare. This will help ensure that Part D drugs are only prescribed by individuals who are qualified under state law and under the requirements of the Medicare program, and it implements the longstanding recommendation by the Department's Office of Inspector General. The same rule also gives CMS the authority to revoke a provider's Medicare Part D enrollment status under certain circumstances, including if CMS determines that the provider represents a threat to the health and safety of Medicare beneficiaries or has a pattern of prescribing Part D drugs that is abusive. And finally, to reduce prescription drug abuse and diversion, CMS now requires plan sponsors to implement internal controls to prevent overutilization of both opioids and acetaminophen. These steps and many others are transforming Medicare Part D program integrity efforts, making them more data-driven and risk-based, and I look forward to hearing from both the Office of Inspector General and from CMS about the important steps the agency has taken to improve program integrity in Part D. I also wanted to highlight the important bipartisan work of this committee to address one of the OIG's recommendations to improve Part D program integrity. In 2014, the OIG once again recommended that CMS seek statutory authority to implement a pharmacy lock-in program that would allow prescription drug plan sponsors in Medicare Part D to develop safe prescribing and dispensing programs for beneficiaries that are prescribed high volumes of controlled substances. And I introduced legislation on this issue immediately following the OIG's earlier work, the Medicare Prescription Drug Integrity Act of 2013, and I'm gratified that H.R. 6, the 21st Century Cures Act, passed overwhelmingly by the House last Friday, acts on this recommendation and gives Part D plan sponsors the authority to establish these lock-in programs. This provision strikes the right balance to protect the integrity of the Part D program and improve patient safety while carefully protecting beneficiary access. It's a strong example of what this committee can achieve when working in a bipartisan manner to implement common sense policy solutions. So I look forward to hearing from the Assistant Inspector General Maxwell about the OIG's outstanding recommendations and from Dr. Agarwal regarding CMS's ongoing efforts to strengthen Part D. Thank you, Mr. Chairman, for convening this hearing. I was going to yield to, I don't know if anybody else wants the time, I guess not, so I'll just yield back. Thank you.
Thank you, gentlemen, for yielding back. I might comment on the opening statement. You can see that I think this committee does its best work when we're united, and it's clear that that's the case today. I also want to make sure I ask unanimous consent. If any other members want to introduce opening statements to the record, they can do so, and without objection, those documents will be accepted. You're now aware that the committee is holding an investigative hearing, and when doing so has the practice of taking testimony under oath. Do either of our witnesses today have any objections to testifying under oath? Both of them say no. The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do either of you desire to be advised by counsel during your testimony today? And both say no. In that case, you please rise and raise your right hand, and I will swear you in. Do you swear the testimony you're about to give is the truth, the whole truth, and nothing but the truth? Thank you. You may be seated. Both witnesses said yes. You are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now give a 5-minute summary of your written statement. We'll start with you, Dr. Agarwal. You begin.
Great, thank you. Chairman Murphy, Ranking Member DeGette, and members of the subcommittee, thank you for the invitation to discuss CMS's recent work to improve the Medicare Prescription Drug Program, also known as Medicare Part D. Our objective is to ensure that all Medicare beneficiaries receive the medicines they need while reducing and preventing prescription drug abuse. We appreciate the subcommittee's continued focus on the problem of opioid abuse and efforts to combat the overutilization of prescription drugs. We also thank the OIG for its work to help us improve the Part D program. The growth of prescription drug abuse has touched providers, pharmacies, and beneficiaries in the Part D program. As this committee has heard, the problems with overutilization, drug diversion, and a variety of other issues are far-reaching. The statutory construct of operating the Part D program requires CMS to work through hundreds of plan sponsors, which presents unique challenges to our program integrity efforts. It requires a coordinated, multifaceted approach to address the major players in Part D, including prescribers, pharmacies, PBMs, and plan sponsors. CMS has taken concrete actions in recent years to strengthen the Part D program and address weaknesses identified by the OIG and others. One element of these changes has been enhancing the culture around Part D to include a focus on program integrity, one that emphasizes prevention over the pay-and-chase model, instituting and implementing new administrative authorities to ensure only legitimate providers are prescribing drugs to beneficiaries, and improving collaboration and data sharing with Part D plan sponsors, law enforcement, and other stakeholders. In particular, CMS is focused on holding sponsors, prescribers, pharmacies, and our contractors accountable for prescribing that is consistent with our goals and values of providing safe, high-quality, evidence-based care. CMS has also taken steps to protect beneficiaries by ensuring that they are receiving prescription drugs from legitimate providers. CMS has announced plans to undertake a major programmatic change which will require prescribers of drugs paid for by Part D to enroll in Medicare, just as they would in Parts A or B of the program, and have begun outreach efforts to enroll over 400,000 prescribers by January 2016. We will then begin enforcement in June 2016 by requiring plans to deny Part D prescriptions that are written by prescribers who do not meet the necessary requirements. During the enrollment process, prescribers will be subject to the same risk-based screening requirements which have already contributed to the removal of nearly 575,000 provider and supplier enrollments from the Medicare program since the enactment of the Affordable Care Act. This enrollment standard will directly address issues OIG has noted, including prescribers by excluded or invalid prescribers. Through new point-of-sale edits, Part D plan sponsors will be required to implement. CMS also has new authorities to remove problematic prescribers from the Medicare program for abusive prescribing behaviors. Together, we believe these new policies will help prevent bad actors from taking advantage of the Part D program and potentially harming beneficiaries. We are also utilizing Part D data more effectively. CMS is doing more to analyze and share data with Part D plan sponsors to enhance the detection and prevention of fraud and overutilization in Medicare Part D. This includes the overutilization monitoring system, in which CMS identifies beneficiaries with potentially dangerous opioid utilization. We share a list of those beneficiaries with plan sponsors, which are then expected to use enhanced drug utilization review strategies, such as case management and point-of-sale edits, to prevent continued overutilization. Further, plans are now allowed to share information about potentially dangerous beneficiary opioid use, actions that can help prevent beneficiaries from changing plans to avoid detection. CMS has also developed high-risk pharmacy and prescriber assessments, which we produce for Part D plan sponsors. These assessments contain a list of pharmacies or prescribers identified by CMS as high risk, based on a methodology which goes beyond a simple outlier analysis. We provide plan sponsors with this information so they can initiate investigations and conduct audits, and ultimately terminate pharmacies or prescribers from their networks. Since 2013, plan sponsors have taken action against hundreds of pharmacies as a result of our pharmacy risk assessments. Our newly implemented Plato system allows plan sponsors to report back actions they have taken to address issues posed by pharmacies and prescribers. We have also taken steps to improve data sharing with our colleagues in law enforcement. From January 2010 through the present, CMS made nearly 2,300 referrals to law enforcement. We're working closely with the OIG to prevent bad actors from fraudulently extracting trust fund dollars. Since 2013, CMS has been referring providers who qualify for permissive or mandatory exclusion from participation in federal health care programs to the OIG for exclusion. CMS takes seriously the recommendations of the OIG and has taken strong steps to improve the integrity of the Part D program. We are committed to continue to work with the OIG, this committee, and others as we strengthen Medicare Part D. I look forward to answering your questions. Thank you.
Ms. Maxwell.
Good morning, Chairman Murphy, Ranking Member DeGette, and other distinguished members of the subcommittee. I'm pleased to join you today to discuss how we can protect Medicare's prescription drug program from fraud and abuse. The OIG has made a strong commitment to help safeguard Medicare Part D. Just last month, OIG special agents and other law enforcement personnel fanned out across the country to conduct the largest criminal healthcare fraud takedown ever. A number of the arrests were for doctors and pharmacy owners involved in prescription drug fraud. And there are likely to be more arrests because we have found that Part D continues to be vulnerable to fraud. Recently, we identified 1,400 retail pharmacies with questionable Medicaid payments. In one example, a Detroit area pharmacy billed for commonly abused pain medications, opioids to be exact, for 93% of its Part D patients. As this committee is well aware, abusing opioids can lead to patient harm and even death. It is also tied to illegal drug trafficking, which is why the OIG is not stopping with the recent takedown. As our special agents investigated and built these cases, OIG analysts were already proactively mining the data to identify new leads to help us, CMS, target and shut down this problem. As important as our law enforcement efforts have been, we cannot arrest our way out of this problem. We have to strengthen our defenses. OIG has several outstanding recommendations for fixing some of the systemic vulnerabilities that allow fraud and abuse to slip through undetected. To start, CMS can better leverage data as a tool to improve oversight and to keep up with the ever-evolving fraud landscape. This should include collecting the data necessary to ensure that plan sponsors, the hundreds of private companies that administer the program, are effectively protecting the program. These plan sponsors are Part D's first line of defense. Currently, as we've already heard, CMS does not require these plan sponsors to report on the fraud and abuse that they identify. While plan sponsors may report this information voluntarily, given the choice, we found that less than half chose to report. Information on identified fraud and abuse, as well as how sponsors handled these cases, would help CMS assess the effectiveness of sponsors' efforts to protect Part D. Better leveraging data should also involve expanding the analysis of the data CMS already collects. We recommend that CMS and plan sponsors monitor payment data for a wider range of drugs prone to abuse. CMS does have several key initiatives underway focused on opioids. And while opioid abuse is certainly a major concern, OIG has identified questionable billing patterns related to other drugs. This includes non-controlled substances, which can present a substantial financial loss to Medicare and can be abused in combination with controlled substances. In addition to better leveraging data, plan sponsors and CMS should buttress current defenses by adding the following 3 oversight tools to their current efforts. First, plan sponsors and CMS need to implement stronger payment controls to stop paying for things they shouldn't be paying for, like payments for drugs prescribed by doctors excluded from the Medicare program, or paying for illegal refills of controlled substances. Second, another powerful preventative measure would be a lock-in program that restricts certain beneficiaries to a limited number of pharmacies and prescribers. This tool allows for better monitoring to prevent at-risk beneficiaries from overutilizing drugs that might harm them or diverting those drugs for illegitimate use. Finally, we recommend that CMS improve processes to recover inappropriate Part D payments. Our recent law enforcement and data mining efforts show that the current defenses are not strong enough. Plan sponsors need to reinforce that first line of defense, but they cannot be the only line of defense. Ultimately, it is CMS that is responsible for ensuring the integrity of Part D. For our part, we'll continue to focus our full array of resources on protecting the program, and we stand ready to work with you, with CMS, and others to improve program integrity. At this time, I'm happy to be of assistance and answer any of your questions. Thank you so much.
Thank you. I'll now recognize myself for 5 minutes as we go through this. First of all, we know that prescription drugs and medications can heal, they can reduce symptoms, they can keep people out of the hospitals. Dr. Agarwal, does CMS have any kind of report that really takes into account of as the prices have gone up in Medicare Part D? Has there been any corresponding decrease in hospitalizations or doctor visits? Is there any report of that type out there?
Chairman, that's a good question. I'm not aware of a report along those lines. I may have just not seen it, so I'm happy to take that question back.
Thank you. I wish you would. Ms. Maxwell, you pointed out in your testimony about 9 unimplemented recommendations that the OIG identified. So as she stated that, Doctor, some of those go all the way back to 2006. Does CMS agree with the recommendations made by OIG?
I think we do agree with the recommendations. I think we've expressed that in writing to those reports. What I would emphasize is these are all recommendations that we are working to make progress on. I think it's very fair to say, that we need to continue to work on it, need to get to completion. These are often multifaceted recommendations that require, multiple levels of implementation.
But you recognize some of these go back to 2006, so I'm sure many members are going to key in on trying to get some commitments from you to get that done. But let me focus on one of those. The OIG recommended that CMS exclude Schedule II refills when calculating final payments to plan sponsors at the end of each year. So what action has CMS taken to implement that recommendation? Ms. Maxwell, can you answer that first? Do you know if they've taken action on that?
Absolutely. It is my understanding, and this is one of the recommendations in which CMS did not concur with the recommendation. Of 7 of the 9 initially CMS did concur with, there are 2 that they didn't. This is one of them. It is my understanding that CMS is concerned about the data that's available, and the data does not make it obvious what's a partial refill versus what's an illegal refill, and that they have instituted actions to make it more clear in the data. Our position is once the data is clear, then you have the opportunity to put in an edit, and we would continue to recommend that they do put an edit to stop those illegal refills.
Dr. Agrawal, what's your plan of action here?
Yeah, I think Ms. Maxwell has characterized that correctly. So our concern is that the data is not completely accurate at this point. Early refills of Schedule II drugs are illegal. We, of course, don't support early refills of those drugs. However, partial fills, particularly for beneficiaries that may be in long-term care facilities, are totally legitimate and may actually help to address pain and other issues that they have. So what we are doing is working with plan sponsors to clarify coding requirements so that we can differentiate the legitimate payments from the illegitimate payments, and then would be seeking to make the kind of change that is being described.
And as part of that, hopefully you'll also be going after people who have made the wrong claims and getting that money returned. On page 3 of your testimony, Doctor, you have mentioned the President's budget proposes to provide the Secretary with new authorities to suspend coverage and payment for drugs prescribed by providers who have been engaged in misprescribing, to suspend coverage and payment for Part D drugs when those prescriptions present an imminent risk to patients and require additional information on certain Part D prescriptions, such as diagnosis, incident codes, and conditional coverage. Do you have any estimate that this will actually save money in terms of reducing some of the fraud and abuse to implement those recommendations?
Yes, I think these kinds of recommendations really go at the heart of prevention, moving away from the pay and chase model that others have commented on. We did promulgate policy, as you know, last year requiring enrollment of prescribers, and also with that implementing the ability to revoke providers for abusive prescribing. I think all of those things really do take a very strong step towards prevention, just as we have done in other parts of the program and have been shown to be effective.
I hope that's something you can give us some numbers on in terms of what you estimate that would be savings to Medicare Part D. That would be important to us if we implement those. Let me mention something else here. This is on Medicaid, but it's important because a report just came out in March issued by the HHS Office of Inspector General and found that 92% of Medicaid-enrolled children who were prescribed antipsychotic medications lacked, quote, medically accepted pediatric indications, unquote, that would warrant such prescriptions. There was instances there of very young children being prescribed antipsychotics, 4-year-olds. It was a very disturbing and alarming report. That 92% number of not medically indicated was absolutely astounding. So given that, I don't expect you to know this today, but if you do know, I'd like to know what steps CMS is taking to root out the providers who are prescribing children powerful psychotropic medications when it isn't medically necessary. Would you make sure you get back to us on that?
Absolutely.
And finally, the OIG has recommended that CMS implement an edit to reject prescriptions written by excluded providers. So, Ms. Maxwell, what actions has CMS taken to implement that recommendation of those who aren't supposed to be prescribing at all?
It is my understanding that the sponsors are required to be monitoring excluded providers and making sure that the payments don't go to them. However, when we did look, we did find that CMS did accept PDE records from the sponsors that included excluded providers. There was about $15 million in gross payments over a 3-year period. So again, we continue to appreciate the steps that have been taken, but there's obviously a need for further steps and stronger payment controls to be put into place.
I think I'd like to follow up, but I'm out of time, so I'll now turn to Ms. DeGette for 5 minutes.
Let me sort of extend that previous line of questioning, which is we're talking about the OIG report on Medicare Part D integrity, and the report notes, quote, CMS relies on plan sponsors to be the first line of defense against fraud, waste, and abuse in Part D. Wondering if both of you can each comment on the role that plan sponsors play in this first line of defense against waste, fraud, and abuse. I'm wondering what tools they use and what can be done. Dr. Agrawal?
Sure, thank you. I do think the role of Part D plan sponsors is extremely important since they are paying claims or PDE records directly. Let me just address maybe the prior point about excluded providers first. I think it's absolutely indefensible for a Part D plan sponsor to pay the prescription of an excluded provider. Now, we have implemented edits behind those plan sponsors to indicate when they have done that so that they can make the appropriate recoveries on their end. I also think prescriber enrollment and the screening requirements that I mentioned earlier will go a long way because it will move those edits from after the PDE record to the point of sale when we have all 400,000 prescribers enrolled in the program. So we can clearly buttress the Part D plan sponsors, but their role is absolutely vital. I think they need to be on top of the data. We share a lot of data with them so that they're aware of who the outlier prescribers and pharmacies in their networks are. They also have the ability to implement drug utilization reviews and other kinds of programs, including case management, to stem both abusive prescribing as well as abusive utilization.
Well, let's talk about that data for a minute because they're not required to report the data on potential fraud and abuse. And in fact, the percentage of plan sponsors that voluntarily report this has declined over the last few years, down from 40% in 2010 to 35% in 2012. Do you have any more recent data about the trends on this?
I don't think we have more recent data that I can share today. However, this is an area that we have been working to make progress as well. So as I mentioned, we give data to the plan sponsors on a quarterly basis, and just this year implemented a system for them to be able to report back to us what actions they took as a result. I think that system, which allows the data to be reported and then for it to be searchable and analyzable, has been an important step moving us towards better reporting from the plan.
What's your view on this, Ms. Maxwell?
It's absolutely true that, as I said in my oral, that the sponsors are the first line of defense. They administer the program, and they're the ones that are paying the pharmacies. But CMS, as I said, is the second line of defense. And if things do slip through the processes and edits they have in place, it is incumbent upon CMS to have a second line of defense to prevent that from happening. That's what prevents the federal government from actually reimbursing the mistakes the sponsors might be making.
And do you think CMS is doing enough to encourage that?
I think CMS has made significant strides in response to many of our recommendations, and of course we outline the 9er report that we believe are important to be included in their ongoing effort to improve program integrity.
And what about the plan sponsors' fraud detection programs themselves? Do you think that the plan sponsors are doing enough, or can they be beefing up that?
If we had the data about the fraud and abuse incidents that they are detecting, as well as the data about how they're responding, we would be able to answer that question with more authority. We really don't have the visibility that we think is necessary to hold them accountable.
Is that something, Dr. Agrawal, you think you could provide?
Well, as I mentioned, we are getting some data from plan sponsors, and in particular, we are focused on where we give them a clear lead, such as an outlier pharmacy or an outlier prescriber. What are they doing to investigate that lead downstream and then take the relevant actions? What we have found is certain plan sponsors are actually quite good at following up. So we've been able to see hundreds of pharmacies be excluded from networks because of the leads we give them. We also conduct compliance reviews of plan sponsors to make sure that program integrity processes are a robust part of their operations. Again, some plan sponsors I think do quite well there, and others have opportunities for improvement.
Well, this is an area where it seems like there could be a lot of problems, and the OIG has recommended making it mandatory that they report potential fraud and abuse. I'm wondering, first, Ms. Maxwell, could you comment on that recommendation?
Absolutely. As you have pointed out, given the current state of affairs that is now currently voluntary, we don't have full compliance.
Right.
And so we believe that we will not have full compliance unless it's mandated. And without the comprehensive reporting of that data. We can't look across the entire program to
And see. Dr. Agrawal, what's your agency's response to that?
Yeah, I think we conceptually agree with that, the notion a lot. I think the question for us is what kind of reporting is the most beneficial for other plan sponsors and the agency? And so implementing something like the Plato system, giving them leads, and then getting results from those leads is a step towards answering exactly that question of what kind of information return is useful to the agency and would be useful to other plan sponsors. I think as we get more information and get better understanding of the utility, we'll be able to require more of plan sponsors.
I'm sure we have more questions around that line, too. Thank you.
You now recognize the gentlelady from Tennessee, Ms. Blackburn, for 5 minutes.
Thank you, Mr. Chairman, and I'm going to follow right along with what Ms. DeGette was saying. It is troublesome when we hear, and Ms. Maxwell, of course, you all have done so much work on this with the voluntary nature of the reporting, and you have recommended that they make it mandatory. And so, Dr. Agrawal, what are you doing to beef up the compliance? You can say, well, we have Plato, well, we have this, but what are you doing to enforce this? How do the people that work at CMS understand this is an imperative? You've got to do this. I mean, how do you communicate that?
I think we take all of OIG's recommendations as important contributions, as imperatives. We do work towards
wait a
implementing
minute.
them.
They're not contributions. They have pointed out to you, this. Let's not even start down that road. It's not a contribution. It is, you are doing this wrong, you are wasting money, the fraud has been identified. Let's just say it like this. They've got 9 recommendations on the table. Do you agree with those recommendations, yes or no?
I think we've indicated that we largely agree with those recommendations, yes.
That's not the question that I asked, yes or no.
Well, I think Ms. Maxwell has pointed out that the agency has agreed with 7 of the 9
You're not-
recommendations.
Okay. Well, the problem is, what are you doing then to take an action, and what is your timeline? You seem to come here and punt, and we've got another report that came out this morning. You're saying, oh, by the way, it's only 2 months late. You're 2 months late with your report. People that in the private sector that deliver a report 2 months late generally are, they have other problems. Okay, so let's look at this. You're saying you have recovered $454 million and that your fraud prevention system is returning a 10-to-1 ratio on this investment. And you're very proud of that. But you've got a lot of other waste that is out there. So I want to know from you specifically, how are you enforcing the recommendations, and what is your timeline for bringing your agency's work into compliance on a program that is really important to our nation's seniors? And that's not that difficult a question. Now, getting the work done, obviously, that's a little bit harder for you. But we want to know specifics on your enforcement and specifics on your timeline of meeting this.
Yeah, first, Congresswoman, let me just say on the Fraud Prevention System report that those numbers have been certified by the OIG itself. And this was a report that we worked on in conjunction with them throughout the timeline.
I'm fully aware of that.
So I think the 10-to-1 ROI is positive, obviously, a good development for the system. As to your questions about the various recommendations, I'm happy to take that back, and we can give you responses for each recommendation, what we have done to implement them. I think on every recommendation we have worked to make progress, to implement various systems and changes towards finally completing that recommendation, but these recommendations do take time to implement.
Okay, you said you had the authority to do the job. We know that you have the money and the personnel. Why does the job not get done? Is it not a priority?
This is an absolute priority. We have many staff focused every day on the integrity of the Medicare program.
Do they understand that they're expected to meet a timeline? Do you all have a timeline? You still haven't spoken to the timeline.
I think it depends on which recommendation you're referencing.
All of them. You can't pick and choose on this. You've got a list of recommendations. You have had waste, fraud, and abuse identified. You know you've got problems with the opioids. You know that voluntary reporting gets you part of the way, but it doesn't get you all the way, that this needs to be made mandatory. So, as the leader, what are you doing to make certain that there is a set timeline? When is the timeline? Is it the next report? Is it the next hearing? Is it the end of the year?
Yeah, so let me give you an example, Congresswoman. So we have been very specific when it comes to something like prescriber enrollment, which will actually go towards resolving at least two of the recommendations I believe that OIG has put forward around excluded providers or other kind of invalid prescribers. We have stated, we promulgated the necessary rulemaking last year. We are now working with Part D plan sponsors to get these prescribers enrolled so that we don't cause an interruption in legitimate access to services. And we have said that that enrollment requirement needs to be met by January 2016 between both the plan sponsors and CMS working collaboratively together. We will then implement point-of-sale edits behind that enrollment in June of 2016, which I think will take a significant step towards really eliminating excluded prescribing or other invalid prescribing.
So basically, you're giving yourself a year to come into compliance with something that you know has been a problem.
Well, I think that
highlights.
You recognize Mr. Pallone for 5 minutes. We can let him answer? I'll let him answer. Go ahead. You can let him answer. Let me do that first.
Thank you. I think it highlights some of the technical challenges in actually getting this work done. So we have to be very careful to actually enroll 400,000 prescribers so that we do not interfere in legitimate access to services that the Part D program provides beneficiaries. We balance that against the need to do this quickly and effectively to stem the various weaknesses and issues that the OIG has correctly pointed out. This is a balance we work to achieve every day. So, yes, it takes time. It takes time for prescribers to get up to speed on the requirements and get enrolled. It takes time for our Part D plan sponsors to initiate the necessary actions on their part and get the point-of-sale edits in place as well.
Thank you. Mr. Pallone.
Thank you. Both of our witnesses here today have studied a growing phenomenon that's deeply concerning, and that's the overprescribing and or the overuse of opioids in Medicare Part D. This is an issue that we've all worked on for many years. In response to OIG's earlier work on this topic, I introduced the Medicare Prescription Drug Integrity Act of 2013. Since that time, OIG has repeatedly recommended that CMS seek statutory authority to restrict certain beneficiaries to a limited number of pharmacies or prescribers when warranted by excessive or questionable billing patterns. This practice, commonly referred to as lock-in, I mentioned in my opening statement, has been successfully implemented in the private insurance market and some state Medicaid programs. In the 21st Century Cures legislation the House overwhelmingly passed on Friday, there's a provision that would allow Medicare Part D plan sponsors to use these types of drug management programs to curb potentially harmful use of opioids and other controlled substances. And that provision, as agreed to in the legislation, strikes the right balance between protecting beneficiary choice and access while also improving continuity of care by ensuring that those high-risk patients obtain and fulfill prescriptions for controlled substances only from designated providers. And I think that's a big step in the right direction. So let me ask some questions. Mr. Maxwell, or Ms. Maxwell, can you summarize OIG's findings that have led the agency to repeatedly recommend that Congress gives CMS authority to allow Part D plan sponsors to create these so-called lock-in programs?
Absolutely. As our current data brief shows, the rate of increase of use of opioids within Part D has far outpaced the general increase in drugs. In fact, it's grown 156% since the inception of the program. We also see, as I mentioned, the pharmacy fraud, where we see the pharmacies allowing for opioids to flow into the streets and be diverted. This poses not only a patient harm issue for the beneficiaries, but also as a public health issue, for some of those things that flow into the streets end up back on pharmacy shelves, which affects all of us. So it's a significant issue, and we believe the lock-in would be a significant move forward in protecting the program, beneficiaries from patient harm, as well as the program from significant financial loss.
Thank you. Dr. Agarwal, do you believe that if the pharmacy lock-in provision in 21st Century Cures was signed into law, CMS would have a much-needed tool to address opioid abuse and overprescribing in Part D? And have these types of lock-in programs been successful in curbing opioid abuse in other programs?
Yeah, I would certainly agree with Ms. Maxwell that we have seen beneficiaries that are really at safety risk from the levels of utilization of their opioid medications. We have been supportive of this kind of legislative change to provide a lock-in approach. It is part of the President's budget. I do believe that it would have impact, as it has, as you have already pointed out, in both the private sector as well as in various Medicaid programs.
Okay, I want to switch to that report that Ms. Blackburn mentioned, the fraud prevention assistant report that the agency released this morning. The FPS uses predictive and analytics to detect troublesome billing problems and providers in the Medicare program. And after 3 years of operation, CMS today reported that the system identified or prevented $820 million in inappropriate payments in the program's first 3 years. So, Dr. Agarwal, first of all, I want to commend you on your work on the FPS. In its third year, how has the program changed and matured? And let me throw in the second question, too, because of time. Does CMS plan to expand the program to Part C and Part D in the near future? And what additional plans does the agency have to expand the FPS to additional fraud detection activities?
Sure, thank you for the question. Currently, the FPS streams all Medicare A, B, and DME claims, so about 4.5 million claims per day. I think what we have seen over the last 3 years in terms of evolution of the program is more models being implemented, more sophisticated models being implemented that not only look at outlier behavior, but are truly predictive models based on the input of our own investigative field staff, as well as the input of law enforcement, both OIG and DOJ, based on prior kind of patterns of fraud and abuse that they have noted. So that's one really big change, is on sort of the technology side and just improving the modeling. The second is making sure that these leads are actually being followed. So this was almost a cultural change, or just a contractor accountability change, to make sure that our program integrity contractors took these leads seriously. They formed a substantial part of their workload, and they were driving towards real administrative outcomes as quickly as possible. I think what we'll continue to do with this program is continue to leverage the technology to implement new approaches like edits, so that claims can be stopped from being paid before they're actually ever paid. We've been doing some of that already in the first 3 years, and we're looking to expand that capability substantially going forward. I think also just the maturing of the modeling will facilitate this process. To your question about other data sources, we have started to fold in Part D PDE records, and we'll be looking to do that more. I think in Part C, we still have the challenge of getting accurate encounter data from plan sponsors. So we're still working with the relevant parts of CMS and plan sponsors to help improve that encounter data.
Thank you. Thank you, Mr. Chairman.
You can now recognize Mr. Barton for 5 minutes.
Thank you, Mr. Chairman. I guess the first thing we ought to do is thank HHS and the Inspector General for conducting the investigation and actually beginning to try to correct the problem and at least identifying some of the bad guys. That's a good start. My first question, I guess, would be to Dr. Is it Agrawal? Is that correct?
You nailed it.
Well, how about that? Just a lucky guess, huh? How in the world can somebody be on Medicare Part D if they're not enrolled in Medicare? If I heard correctly, you said some people are actually getting the benefit, but they're not in the program. I don't understand.
No, sir, it's not on the beneficiary side of the equation. It's the prescriber, the physician or advanced practice nurse, for example, who actually sends a prescription in, hands it to a patient. Currently, or prior to last year, there was no specific enrollment requirement for the provider. There is now, so going forward, all prescribers are going to have to come into the program, be subject to the same screening standards as in the rest of Medicare.
Okay, but prior to this year, a provider could reject Medicare patients but prescribe Medicare Part D prescriptions.
Correct. It's been a huge program integrity focus to bring this up to the rest of the level, to the level of the rest of the program.
Okay, but that's no longer a problem. That's one loophole that's been closed.
We are in the process of closing it as we get through enrollment. As I mentioned, we have to enroll 400,000 prescribers by January.
Okay. And if they have a doctor that's not in the program, you just send a letter to the patient saying that's not a valid prescriber. Is that correct?
Yeah, so the balance with beneficiary access to medications is important. What we have done is created essentially a transition period. So if a beneficiary takes a prescription to a pharmacy from a prescriber who's not enrolled, they will get that information, but they will also get the medication so that there's no interruption in their therapy. They will not get it the second time. By that time, we would have expected the provider to either be enrolled or for the beneficiary to go to a different provider.
Okay. Now I'm going to switch to Ms. Maxwell. One of the recommendations that hasn't been acted on, but apparently y'all are beginning to, the program's beginning to act upon, is this idea of mandatory reporting from the plans. I'm not a big fan of mandatory anything, except people paying their taxes, I guess. That ought to be mandatory. Why not go the other way? Why not create... I heard that. Voluntary compliance, but you'll go to jail if you don't voluntarily comply. But, all right, a minor point. Why not go to the other way and provide an incentive to the plan that you don't have to report, but if you do and it really is fraudulent and we recover some of the program funds, we'll give you a percentage of the monies that are fraudulently had been fraudulently paid and then recovered. Why not create an incentive program that works for me? And I think most Republicans would prefer it. Now I may be wrong, but I'd rather have an incentive to do it than a mandate they have to do it.
You know, the heart of our recommendation is to have the visibility to oversight. So as long as we had the data and the visibility to what the plan sponsors were doing to protect the program, that is really ultimately what we're after.
Congressman Gingrich, when he was Speaker, put in, or at least requested that this committee put in a program where you could create a hotline that people could call into. And if it turned out that and this wasn't just for Medicare, this was before Medicare Part D, obviously, but if there was fraud involved and somebody reported it and it was proven and stopped, the person who reported it got some sort of a bonus. And that'd be another idea to think about. Go back to the doctor. This is my last question. And you may have to get back to me on this. Just at the basic level, I'd like to know where you think the primary cause of the fraud is. Is it from the patient standpoint? You got phantom patients, perhaps. Is it from the pharmacy standpoint? Is it from a plan who's overbilling even though they don't have patients? Or is it possible it could even be in the government itself where they work in conjunction with the plan to create fraud? Do you have any data on that?
I think what we see is that overutilization in Part D is multifaceted. It occurs at patient, prescriber, the pharmacy, which is why the response to it, and I think the OIG has pointed this out as well, the response to it has to be multifaceted. The program has to try to address all of the different areas that fraud or abuse could be occurring.
If you identify the most prevalent area, then you put most of your assets there, you'll have a better chance to get a greater return on your investigations. With that, Mr. Chairman, I yield back.
Thank you. The gentleman yields back. Now recognize the gentleman from Massachusetts, Mr. Kennedy, for 5 minutes.
Mr. Chairman, thank you. Thank you for holding the important hearing. Thank you to our witnesses once again for coming back. I'm going to touch on some trying to flesh out a little bit of some of what my colleagues have already touched on for both of you. Obviously, Medicare Part D is a large and important program serving millions of seniors across the country and a good deal of them in my district. Given the scope and the number of transactions involved, proactive data analysis is an essential tool to focus on fraud detection and enforcement efforts. The OIG data brief does just that, highlighting some notable outliers when it comes to pharmacy billing. In particular, the suspicious prescriptions for opioids are especially troubling given the nationwide epidemic that we've heard about at previous hearings and some of my colleagues have already touched on. So according to the data brief, quote, spending for commonly abused opioids grew at a faster rate than spending for all drugs. That was on page 3, I believe. So, Dr. Agarwal, it's my understanding that the initial comparison with 2011 data shows that there's been a substantial reduction in the number of acetaminophen and opioid overutilizers. I was hoping you can try to flesh out a little bit more about CMS's measures to prevent the overutilization of prescription medications within the Part D program?
Sure. So I think where there are, so again, multiple facets to the issue, where there's beneficiary overutilization, where we can identify beneficiaries that have exceeded what we would consider kind of standardly accepted safety thresholds. We share that information with Part D plan sponsors through our overutilization management system. That gives them the specific beneficiaries that they can then implement, I think, more proactive drug utilization reviews around, including case management. What we've seen when we focus on things like Schedule II drugs is a 30% decline in the prevalence of those beneficiaries, which shows that both the data sharing and the actions being taken on the part of the plan sponsors is having an impact. And we continue to provide that information on a quarterly basis so that plan sponsors can continue that work.
Thank you. And Ms. Maxwell, you touched on, in your opening statement, one of the pieces that were highlighted in the report, Detroit area pharmacy that billed for commonly used opioids for 93% of its beneficiaries. It amounted to 58% of all of its Part D prescriptions. Can you talk a little bit about OIG's plan for follow-up in the questionable pharmacy billing through your study, and tell us a little bit more about the proactive analysis that you're encouraging MEDIC to take in the broader report?
Absolutely. As I mentioned in my opening remarks, when we were participating in the takedown, we were already mining the data for new leads. We already have 1,400 retail pharmacies targeted that had questionable Medicare billing. We are actively investigating some portion of those, and we've referred the rest to CMS for investigation. So the data brief allows us to see where there are areas for questionable billing, and the next step is to investigate and weed out which one of those really represent legitimate business and which are fraud that we need to pursue either with OIG investigations or in conjunction with CMS.
And Dr. Agarwal, after those are referred over to CMS, what's CMS's next steps?
Yeah, so again, I would agree that that the analytical work is a good starting point for further refinement and then also investigative activity. Now, let me just say, it's the construct of the program that CMS doesn't have a direct relationship with pharmacies. That relationship really occurs with Part D plans. Pharmacies don't enroll or anything like that in the program. For that reason, we have to work through Part D plan sponsors by giving them better data, and then they take the necessary investigative and other administrative actions. We certainly will utilize the information given to us by the IG. So they gave us about 1,000 of the roughly 1,400 pharmacies have been sent over to us, and we've been sharing that, or have shared that already with plan sponsors. In addition, on a quarterly basis, we do similar work utilizing a greater set of variables to identify high-risk pharmacies, and again, share that information on a quarterly basis, which has yielded literally hundreds of pharmacies being excluded from plan sponsor networks.
So, thank you. And then the brief highlights some geographic hotspots as well, some metro areas where average payments for certain drugs are much more than the average nationwide. Ms. Maxwell, in conducting the analysis, did OIG evaluate patterns for all non-controlled drugs, or did you just focus on specific ones?
We chose some examples to highlight the potential problems with non-controlled drugs. So there are other drugs that might be of concern that are not highlighted in that data brief. But the ones we did highlight, again, like the questionable billing for the pharmacies, are worthy of further scrutiny to understand what is happening and stay in front of the evolving healthcare fraud trends.
Great. Thank you, and I'll yield back.
Dr. Burgess, now recognized for 5 minutes.
Thank you, Mr. Chairman. And I think you can tell, I mean, it's great that we're having the hearing on the integrity of the program as it relates to Part D drugs, particularly with respect to opioids. But you can tell there are a lot of general questions about inappropriate expenditures within the various programs at HHS. So, Mr. Chairman, I hope you will take this as perhaps a reason to consider having a general hearing, a general oversight hearing on inappropriate expenditures within the Medicare and Medicaid system. Mr. Barton talked about previous efforts towards the concept of predictive modeling, and it does seem to me that this is an area where this would be perhaps a particularly useful type of activity. I mean, I got a call at 6 o'clock in the morning a couple of Sundays ago that there'd been inappropriate expenditures on my MasterCard. Seems to me that with the amount of data that you all collect on a daily basis, you ought to be able to do a pretty good job of identifying and isolating and investigating unusual trends in expenditures. Is that not possible?
Dr. Burgess, I agree that it is. We have been, as I mentioned earlier, we are looking to include Part D data to a greater degree in the FPS system, implementing new models just around this program as we've demonstrated the impact of the FPS.
It just calls up a question of, the scale of the problem is likely to be much more massive than any recovery that has been affected to date. I do want to ask a couple of questions, and I realize it's a little bit off topic, but I know, Dr. Agarwal, we've talked about this before. Ms. Maxwell, I apologize, I don't remember whether our office has talked to you directly, but it does affect your sphere also. But we had a hospital in Texas, Dr. Tariq Mahmoud, who took $18 million for the development of an electronic records system and basically just put his medical records down in the basement and let the mice eat them. Not computer mice, real furry mice. So what can you all do? I mean, yeah, one of the managers has gone to jail. The doctor will have a trial at some point and likely will face jail time through the Department of Justice. But what can you all do to recover that $18 million that was inappropriately dispensed under the stimulus plan to this hospital chain?
So thank you for the question, and I'm aware of the case. I have to tell you, I think it occurred a while back. So I think the general answer is we do conduct audits of the EHR payments, incentive payments that we make, and where we find discrepancies, we are able to recover those dollars. This was a case that I know we worked on conjointly with the OIG, so I can't tell you if the audit came first or the OIG investigation did. If you're interested in that, perhaps I can take it back. But these audits are meant to address exactly the vulnerability that you're identifying, which is, essentially false statements that you've implemented an EHR, a viable EHR system. We do look at that question.
And yes, to answer your question, or I would be interested, but see, this is the problem, and this is what just drives people crazy. We kind of get into this circuitous stuff between agencies. And I think we've had this conversation before. I'm told it's under investigation. But really, where are we at getting the $18 million that the taxpayers on the hook for sending these dollars down to Dr. Mahmoud? Does either office have an interest in recovering that money?
Of course, all right. Of course we do, and I will happily take that question back. I mean, just to specifically address whether the $18 million have been recovered. I don't want to leave you with a false impression about this particular case. This was something that we did work in coordination with the OIG. It wasn't sort of a turf battle or anything like that. My answer is just I don't know if they identified the issue first and then came to us or vice versa. But we did coordinate across this case.
I actually think it was my newspaper, the Dallas Morning News, that identified the problem, and I brought it to your attention. But I mean, again, this is what just drives people crazy. You have a massive inappropriate expenditure of federal money, and then no one seems to be primarily responsible for going and recovering it, and quite honestly reporting back to Congress about what the status of that recovery is. I mean, in your own statement this morning, Dr. Agarwal, you said, well, this was some time ago. Yeah, it was some time ago. So we'd like the dollars back, please. And I know this individual it's been reported that he's got plenty of assets. So this is something that you would think with the full force of the federal government, Department of Justice, we would be able to go and effect that recovery. Thank you, Mr. Chairman. I'll yield back the time, but I do want to follow up with both of you and understand where the status of this recovery is.
Absolutely.
Thank you. Now recognize Mr. Yarmouth for 5 minutes.
Thank you, Mr. Chairman. I appreciate your holding this hearing. I think, as has been demonstrated, both sides are very much interested in rooting out all the waste, fraud, and abuse that exists in Medicare system. And thanks to the witnesses for the work you're doing. I do have a question about that, but before I do that, I want to take this opportunity, as I often do, to talk about the experience in Kentucky with the Affordable Care Act and the great work that my governor, Steve Beshear, and his team have done in implementing the expansion of Medicaid and what it's meant for our state. We have more than 500,000 people who are newly enrolled in Medicaid and in private insurance. As a result of the ACA, that's in a state of 4.4 million. We've reduced the unemployed rate by almost 50% in Kentucky. In my district alone, the uninsured rate has dropped by 81%, pretty astounding. More importantly, for those who say that this is economically non-feasible, the state employed the Deloitte firm to analyze the prospects for Kentucky's economy over the next 6 years under ACA. and they determined that under ACA, Kentucky would experience added economic activity of $30 billion, the creation of 40,000 new jobs, and I think most importantly from the taxpayer's perspective, a positive impact on the state budget of $819 million. So I think those statistics demonstrate that the ACA can be very, very positive, not just in ensuring people, giving them access to quality care, but also from an economic perspective. So we've talked a lot about Medicare Part D and the fraud provisions and your work in those areas. There's a related issue when we talk about waste as well, and I wanted to talk about prescription drug costs. One of the things that when I was part of the Democratic majority back in 2007, one of the first things we did was to pass a bill to allow Medicare to negotiate with drug providers on cost that was not implemented into law. But I was talking with a physician friend of mine the other day who has done a lot of work in this area, and he was showing me some really incredible statistics about the difference in cost of certain prescription medicines just in my district. And in some areas, the cost was 60 to 70% different from one outlet to another. So my question is, if there are those kinds of potential savings involved just in terms of going from one drugstore or one grocery store to another, why can't we have some kind of systemic approach to that from CMS? Doctor, would you want to respond to that?
Sure. Thank you for the question. I can tell you from my own practice in the ER, drug costs are an important factor in this whole equation, and the ability of people to be able to pay for the drugs that they get. I will tell you, as you pointed out, that this is an area where we do not have legislative authority to kind of engage in the negotiation that you're describing.
Do you think that it could have a substantial impact on saving money for the taxpayers if you did have legislative authority to do that?
I'm not aware. I'm sure there's analyses that have been done. I'm not aware at this moment what the expected impact would be. Perhaps we could get back to you about that.
Well, again, this person has done a lot of work in the area, and he mentioned one drug. I know Ranking Member DeGette talked about saving a billion plus something in one area. One drug that now is responsible for about $8 billion worth of sales in the United States every year, that actually it can be purchased for about 15% of that. So you're really talking there about a savings of almost $7 billion to the system per year if we just had that kind of power to deal with price. So I just mention that for the record because I think that's something that as we look at continuing to make Medicare and Medicaid sustainable over time, we're going to have to deal with the issue of the cost of prescription drugs as well as the fraud and abuse side. So I thank you for
Will the gentleman yield?
I will yield.
So the CBO estimates that allowing CMS to negotiate Part D prescription drugs would save $155 billion over the next 10 years.
That's real money. I yield back, Mr. Chairman.
And obviously, there's more to it than that, and we will continue that discussion. Thank you. I now recognize Dr. Bouchon for 5 minutes.
Thank you, Mr. Chairman. I was a surgeon before, and so I'm intimately familiar with the situation. And the bottom line is, it seems to me that nobody out there is defrauding the government over Lasix or Hyzar or to a large extent. I mean, in my view, we're talking about narcotics. We're talking about a funding stream from the federal government that is helping to facilitate the use of narcotics in our country. I mean, that's not the only issue, but that's a huge part of it. Without the funding stream, the problem goes away. And so there are multiple funding streams, and people that abuse narcotics, people that sell narcotics, when they find an avenue to get that paid for in some way, they will take it. And so my point is there are a lot of other issues other than just payment that this subcommittee has been trying to address. The interconnectability amongst EMRs, including those at pharmacies at the state level, at the federal level is critical so that we know who's prescribing these medications better than we know today. We know who's using these medications better than we know today. And it's going to take a multi-agency approach at the federal level to address this problem. The payment is only one piece of the pie, right? Payment's a big part of it. We had a meeting of the Doctors Caucus this morning with the Surgeon General of the United States, a very impressive physician who we talked with him about trying to address this and using his national stage that he potentially has to address this problem. I've tried to work with the FDA, with the states, with physician organizations, and many others. So this is a problem we're going to have to tackle, and I want to thank this subcommittee and the chairman for bringing that multiple hearings on that. So the question I have, Dr. Agarwal, is that how much communication with the other agencies do you have, and is there the development of a plan that's coming together maybe to address this problem, knowing that the big problem why you're being defrauded in Medicare Part D is because of the narcotics. I mean, that's the biggest problem. We all know it.
Yeah,
What's
thank
the
you
plan?
Thank you for the question. So I had to highlight a few things. First, the Secretary of HHS has identified prescription drug abuse as a major priority for the department, and there's a sort of three-part strategic approach to addressing this issue that the department has taken on, inclusive of all of its agencies. So one is exactly what you're describing, which is communication with the provider community to make sure that prescribing is appropriate, that utilization is appropriate. We are also looking at other facets, so medication-assisted therapy for substance abuse issues and the use of naloxone, for example, for emergent overdose issues. CMS has a role to play in the broader kind of social landscape, and I think, again, your point that this is not just a Part D issue, but a kind of broader societal issue is exactly right. We are approaching it as a payer, using every lever that we can, from looking at prescribers to the beneficiaries that might be abusing the program, identifying pharmacies that might be part of the problem, and working very closely with plan sponsors. One even sort of broader partnership that I'd point out is the Healthcare Fraud Prevention Partnership, where we're working with not just Part D or C plan sponsors, but the private sector generally, a number of private payers, to look at these issues and others. So we have done, for example, an outlier pharmacy study with this public-private partnership, identified 8,000 pharmacies, not just in the Part D world, but also in the private, just sort of pure private payer world, that we are now looking at and working kind of individually. So I completely agree that partnership is at the center of this. We are trying various approaches to partnership to help ameliorate the issue.
Well, I mean, what does Anthem do, for example? I don't want to throw out any names, but big insurance companies that pay for, that are a payer, right? Because it's for the narcotics, if there's a funding stream, people are going to look to the funding stream to try to obtain these medications. I mean, that's just human nature. What is there anything the private sector companies are doing differently than maybe CMS is doing on that front?
Yeah, also an important question. So I think one of the advantages of the construct of the Part D program is that we do work through the private sector. So the common payers that you could identify are Part D plan sponsors. And so we are able to utilize the exact same tools and approaches that they have in their pure private side for the advantage of Medicare, whether it's step
so you're
therapy,
basically
prior authorization.
You're working through them. I know Medicare Part D works through plan sponsors. We've talked about that. But so you're basically working through them and using their techniques to try to tackle this problem.
Correct. In addition to the other things that we can do from an agency kind of federal leadership standpoint.
Okay, thank you. I yield back.
Mr. Green, you're recognized for 5 minutes.
Thank you, and I want to thank both of you for being here today, and I want to take a few minutes to talk about the recent successes in combating fraud and abuse in the Medicare program. In June, HHS and Department of Justice announced a sweep led by the Medicare Fraud Strike Force, resulting in charges of 243 individuals for approximately $712 million in false billing. This was the largest takedown in the strike force history. More than 44 of the defendants arrested were charged with fraud and related to the Medicare Part B program. Ms. Maxwell, the Office of Inspector General was an integral part of this takedown. Can you tell me more about the OIG's role?
Absolutely. I'd be happy to provide you more details about the national takedown. As I mentioned, it's the largest criminal fraud takedown in the Medicare Strike Force history. About a third of the cases focused on Medicare Part D prescription drug fraud, also focused on Medicaid personal care services and Medicare home health. In particular, focus on the prescription drug. There were 44 defendants charged in related prescription drug fraud. We have...
Go ahead. I was wondering, have those gone to trial yet, or is it too early to do?
Too early. So the takedown just happened last month, so we're still in the process of working through those.
I understand the takedown involves a significant component of prescription drug fraud. Can you elaborate? Is this type of criminal fraud scheme increasingly prevalent in the Part D program?
Yes, we have seen an increase in of 134% of our Part D cases. We have 540 pending cases in Part D alone.
Okay. The Healthcare Fraud and Abuse Control Program, which funds the Medicare Fraud Strike Force, has recently seen record-breaking fraud and recovery efforts as well. In the fiscal year 2014 alone, the program recovered $3.3 billion from individuals and companies facing healthcare fraud allegations. Since its inception in 1996, the program's recovered $27.8 billion. The Affordable Care Act significantly increased the funding for HCFAC, indexing a program's mandatory baseline and funding to inflation, providing over $3 million in additional funding. Ms. Maxwell, how can we build on these successes in the future?
The HCFAC funding has been integral to the success of the OIG. It, as you mentioned, funds our Medicare and Medicaid operations, both in investigations, audits, and evaluations. And as we're looking at this Part D problem, that is the IG's approach. We have recognized this as a priority, and we're taking an all-hands-on-deck approach. So we're using those funds to use all the tools available to the OIG to focus on this issue.
The ACA provided new authorities to combat waste, fraud, and abuse, such as enhanced penalties for fraudulent providers. Ms. Maxwell, how are these new ACA authorities assisting the Inspector General in successfully combating Medicare fraud?
The authorities have been incredibly helpful. We have been able to use our civil monetary penalty and exclusion authorities to help buttress and protect the Medicare Part D.
Okay. Mr. Agrawal, same question.
Yeah, the authorities in the ACA for CMS have also been very significant. You know, what it did 5 years ago was it embarked us on a pathway of enrolling every single provider and supplier that's in the program, subjecting them to common and consistent screening standards, which have led to over 500,000 enrollments now being deactivated or revoked. Bottom line is they can no longer bill the program. So that kind of screening approach has been, I think, extremely effective. We've also obviously implemented other approaches along the way, like the predictive analytics system that we described earlier, to really augment these enrollment activities.
Okay. Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Brooks is recognized next for 5 minutes.
Thank you, Mr. Chairman. I'm a former United States attorney, and so have been involved in, used to be involved when I was in Medicare fraud type of cases, and so I do want to commend you for this huge, massive sweep that just happened. I'm curious if you could share a little bit more about, during the time I was U.S. Attorney, mortgage fraud was kind of overtaking the country, and we had massive schemes involving mortgage fraud. Now it seems that we have massive schemes involving Medicare fraud, and I'm curious whether or not in these investigations you found, are there connections between the different communities, and are there schemes that are more commonly being utilized than others, particularly with prescription drug issues? And I'd like both of you to comment as to, how prevalent were the identity theft issues in these prescription drug cases as well, whether it was identity theft of the beneficiaries or identity theft actually of prescribers. And I'm just curious whether or not you were seeing any sort of certain types of enterprises and certain types of patterns bubbling up in these cases.
Absolutely. We're seeing a wide range of fraud schemes emerging in Part D, certainly in the national takedown that just happened last month. And it can range from small physician or pharmacy to a full-on criminal enterprise. One of the new schemes we've been seeing is the emergence of patient recruiters that go out and are in the community, trusted individual in the community that bring patients into these schemes and bring them in as complicit beneficiaries. The fraud schemes in the takedown, we focus primarily on pharmacy fraud, and we see, for one example, we saw in Miami, 5 pharmacy owners were charged with paying for beneficiaries' numbers so they could illegally bill, and also paying a clinic provider to provide them adulterated prescriptions to bill for drugs they did not dispense.
And so in these different schemes, particularly going back to the patient recruiters, were they also charged, and were they conspiracy charges that were brought against these individuals? Do we have appropriate laws on the books to deal with all of the different actors in the schemes?
I know that we are going after the entirety of the scheme and all the people involved. I'm not a lawyer, so I would want to get back to you with specifics about our authorities to combat this.
Okay. I would be very interested in knowing whether or not, as the schemes, and we found this in the mortgage fraud issues of the 2000s, that people would be recruiting potential home buyers as well who really weren't going to be buying homes. And so I think we could see these kinds of schemes obviously happening here. I'm curious what DEA's role, Dr. Agarwal. It's my understanding that you don't have authority to revoke licenses, that it has to go from DEA to a medical licensing board or to a pharmacy board. What is the type of work that you're doing with DEA, and are there any impediments that you and or DEA have with respect to revocation of licensing, which is, a huge penalty for any pharmacist or any physician or prescriber?
Yes, I would agree with you that licensure, either medical licensure or the specific, Schedule II authority that the DEA license gives you, is incredibly important and valuable to, legitimate prescribers. Those authorities, as you pointed out, are levied somewhere else, either at the state level in the state medical board or through DEA directly. But where we have really tried to get involved is making sure that our licensure information is up to date and that we're taking the relevant downstream actions from any licensure changes, whether it's a suspension or revocation or whatever. The rulemaking that we engaged in last year that I mentioned earlier actually specifically links our revocation authority to the DEA license and needing to have a valid DEA license in place to actually prescribe in the program. So that's a place, I think these are examples of where we can key off the work of other agencies as they engage in their oversight and enforcement responsibilities.
Do you report anything to the licensing agencies of the state yourself?
We do. So we are able to make referrals informally to them about concerning prescribing habits, and we have done that. I think we see a wide degree of discrepancy between licensing boards that actually do something as a result versus not.
Okay, thank you. I have nothing further. Yield back.
Mr. Tonko, you're recognized for 5 minutes.
Thank you, Mr. Chair. This subcommittee held a number of hearings earlier this year to examine the current opioid abuse epidemic. Dr. Agarwal, you mentioned in your testimony that the epidemic has touched all parts of the Part D program. The spending for opioids has increased substantially over the past decade, and the number of prescription drug overdose deaths is staggering, to say the least. We need to use all of the tools at our disposal to combat this problem. Over the past several years, CMS has taken a number of steps to strengthen Medicare program integrity, including measures to prevent overutilization of prescribed medications. In January 2013, CMS implemented the Medicare Part D overutilization monitoring system that requires plan sponsors to have a drug utilization management program in place. So, Dr. Agarwal, how does that system work so as to reduce potential opioid overutilization in the Part D program, and would statutory authority for plan sponsors to put so-called pharmacy lock-in programs in place complement that system?
Sure. The way the system works is the agency identifies for plan sponsors those beneficiaries that are that have very high utilization of things like opioids, using commonly accepted standards of sort of safety thresholds. We provide those specific beneficiaries to the plan sponsors on a quarterly basis, and then require them to take downstream utilization control steps, including case management. What we've seen from the time that we've been doing this and working with plan sponsors in this way is a 30% reduction in the prevalence of those beneficiaries. So clearly, impact is possible, and we're looking to, and we continue to do this to ensure that we get as much impact as we can. I think to the second question, lock-in has been discussed, I think, quite a bit. We, do view it as favorable. It does have potential, good impact in the private sector as well as in various state Medicaid programs. It's part of the President's budget, and we look forward to working with this committee on getting that passed.
And what is the role of the plan sponsors in identifying potential opioid overutilization?
Yeah, the plan sponsors have a critical role in throughout Part D, whether it's with opioids or other Schedule II drugs, other medications generally. I think that's why we've highlighted making sure that they have robust compliance programs in place, robust utilization programs in place, so they can address a wide array of issues. We also engage in a lot of data sharing with them, both about abusive prescribers, abusive pharmacies, outlier beneficiaries. This is a partnership really to ensure the integrity of the Part D program. The agency and Part D plan sponsors really have to work very closely together.
And the system's been in place about 2 years, is that correct?
The OMS system?
Right.
I think that's right, yes.
Okay, and the data that are returning are showing great promise, I understand. Have you seen a reduction in the number of overutilizers in Part D?
Yeah, we have. So, again, of the beneficiaries that we've identified exceeding or meeting a certain safety threshold, and that we've shared with plan sponsors, we've seen a 30% reduction, or roughly 30% reduction in the prevalence of those beneficiaries. We've also exchanged information about acetaminophen because it often is kind of co-ingested with opioids and is liver toxic in and of itself. And there we've seen a 91% reduction in the prevalence of those at-risk beneficiaries.
And you noted in your testimony that there are a number of additional tools in the President's 2016 budget. Those tools would prevent inappropriate use of opioids. Can you elaborate on those offerings that he's presenting to us?
Sure. I think the main one that I can highlight, we've discussed to some degree, is the lock-in approach that would essentially restrict certain beneficiaries to, based on kind of abusive utilization, to select pharmacies and select prescribers. And that's an approach that has been utilized in the industry before. It's a way of trying to balance access to appropriate care and medications against that potentially abusive behavior. So that is something that we view as potentially having significant positive impact, and we hope this committee and others help to work with us on that.
Thank you. And Ms. Maxwell, the OIG data brief noted that there has been substantial growth in spending in Part D drugs, especially for commonly abused opioids. How can the OIG's recommendations to combat fraud and abuse help combat this situation, this problem?
Similar to the conversation that you've just been having, we do recommend that a lock-in program be instituted to help address this problem.
Thank you very much, Mr. Chair. I yield back.
Gentleman yields back. Now recognize the gentleman from Oklahoma, Mr. Mullen, for 5 minutes.
Thank you, Mr. Chairman, and thank you, both of y'all, for being here. Doctor, I was, just going over some of our notes on this, and I was just stirred because we've talked before, and we've talked about the abuse of opioid. I'm messing up on that. On opioid. It's not going to come out. Anyways, we know what we're talking about.
Opioid.
Go with narcotics.
Thank you. Narcotics. There. Not enough coffee today. Anyways, as we were discussing it, some statistics came up, and we noticed that Part D spends, on average, the beneficiaries around $105 per individual. In Oklahoma, we see that at $165 per individual enrolled in Part D. And 43% of those enrolled in that receive this drug that is commonly abused. Doesn't that seem a little high to you?
I think Part D is like any other sector of healthcare. We have seen the increasing use of opioid medications throughout healthcare, whether that's in the public sector or in the private. And again, I think we have to be careful. I sort of take this as a physician at heart. There are people who have legitimate pain issues that need to be addressed with these powerful medications.
But 43% enrolled in it in the state of Oklahoma alone? I mean, that seems awfully high to me.
Yeah, I agree. That number does seem high. I think the question that is very difficult for anyone to answer is what portion of that is the totally legitimate utilization that you would expect to see?
Well, in our previous hearing about Medicaid fraud and the addiction of these drugs, I asked you about the high number of beneficiaries being subscribed to methadone as a first line of defense, right? And then these numbers come out from last year, and by CMS's own recommendation, it says it shouldn't be used as a frontline defense. But yet, like I said, in Oklahoma, 43% of those enrolled in Part D beneficiaries are still receiving it. Abuse seems like it speaks for itself through numbers. I mean, as a business owner, I look at financial sheets all the time, especially when we'd go in and we'd go to purchase a company. I could look at the financial sheets and I could immediately tell you where the balances were messed up at. And what we would do when we would see something like that is we would cut that part out to make the company profitable again. If we're seeing numbers like this, isn't it easy to say that until we get a hold of it, we should just cut it out? There's other drugs on the market. We don't have to be subscribing or prescribing this stuff at the rate that we are. Until we understand it more or can oversee it in a better capacity, we should pull it. We do that all the time with drugs, don't we?
So, I'm not an addiction expert, and, I think there clearly is a role.
The numbers speak for themselves. We've had, I don't know how many hearings we've had of this. We've even brought in a detective from Oklahoma that talked about it.
I think there's clearly a role for medication-assisted therapy in the substance abuse space. What we focus on, rather than just eliminating a benefit for an entire group of people, some of whom might really actually need that benefit, is to try to cut away the waste, abuse, and fraud that may be occurring. So that is the role of things like the overutilization monitoring system that looks at bennies.
I get that, but just last year we still had 43% in Oklahoma prescribed to it. That I can't get that out of my head. You can't convince me that nearly half of those on the Part D is needing these type of prescribed drugs when it's not supposed to be the first line of defense. It sounds like to me it's an easy way for them to just prescribe it and move on. There's not enough research being done to make sure that it's not being abused. We're putting people on this and they're blindly taking it because their physician prescribes it to them, and then they're becoming addicted to it. Is this not throwing up red flags? Is there not something that we can do at a more aggressive rate than just simply looking into it?
Well, Congressman, I think you're pointing out what I think the agency has been saying is that this is a multifaceted issue. So whether you're talking about the patient or the prescriber,
and doing is two different things.
Correct, and that's why we are focused on doing with all of these different programs that we have that look at both prescribers, that look at beneficiaries getting the drugs. We have programs around data transparency to send information to prescribers about their own prescribing habits so that they can see how it compares to others. I think this is a complex problem. I'm not sure that a single number is something that the agency can respond to because it really matters what's underneath that number. What is the appropriate utilization that you would like to see?
Sir, I get that, and I'm out of time. Thank you, Chairman, for indulging me there.
Gentleman yields back. Recognize Ms. Castor for 5 minutes.
Well, thank you, Mr. Chairman, for calling this hearing. I think it's an important time for us to take a hard look at Medicare Part D. We're about 10 years into the existence of the program. We have 42 million Americans who rely on the benefit. A lot of the consternation a few years ago was how it was constructed, where you would get coverage and then you'd reach a certain level of coverage and then fall off a cliff into a donut hole, and that made it very difficult for many of our neighbors to get the care that they need. But Thankfully, the Affordable Care Act has brought some significant reforms to Part D. Most importantly is closing the donut hole. As a result of the ACA, 9.4 million seniors and people with disabilities have saved over $15 billion on their prescription drugs, an average of about $1,600 per beneficiary. And I wanted to pull up the statistics for the state of Florida, make sure they're on the record. Since 2010, overall savings for Florida seniors under the Affordable Care Act now has been almost $1 billion, $979 million. And in 2014, Florida seniors saw savings of about $306 million. On average, that's about $884 back into their pocket of our older neighbors. So that's been very beneficial. And just as important as the savings to our neighbors is the overall savings to the program. OMB is deemed Medicare Part D a high error program, meaning it has an improper payment rate above a certain threshold of 3.3%, which amounts to $1.9 billion in improper payments. And we've got to save these dollars, so I really appreciate the work that the IG and CMS has been doing. Clearly we have to do more. And I want to compliment the Medicare task forces, strike forces, especially for the June takedown. In Florida, they arrested about 73 people. South Florida has been a problem area, and I'm going to get into that a little bit more. Ms. Maxwell, what's the explanation for the I know you've said it's multifaceted, but break it down a little bit more. What's the explanation for the increasing cases of fraud nationwide?
I think as we have been talking, there is a lot of money at stake that is enticing. And we are continuing to build the tools to protect the program. Our role in that is multifaceted. As you had mentioned, we have investigations in which we actually go out and try and catch criminals who are defrauding the program. But we also have a role to audit and evaluate and make sure that there are systemic fixes. As I mentioned in my oral, enforcement is never going to be enough. We need to look at the program as a whole and make sure that the plan sponsors have compliance programs in place to protect the program, and that CMS also has strong resources to back that.
So your OIG report emphasizes two areas of opportunity to improve Part D program integrity. First, in the use of data to identify vulnerabilities, and second, in increased oversight by all parties responsible for protecting Part D. And I know this has to include the new emerging criminal networks, because what we saw in Florida, especially in Miami, people that have been convicted of drug trafficking, had served their time, came out of prison, and are now looking at Medicare Part D fraud. What else do we need to be doing to combat these criminal networks? And explain to us what some of their schemes are under Part D.
Absolutely. I think one of the things that we are doing very successfully now and that we can continue to focus on are the Medicare strike forces, in which we partner with CMS and other local and state law enforcement to stay on top of this fraud and address these emerging issues as they hit the ground. As you know, fraud is ever evolving, and so we have to keep
one of the issues, I wish Ms. Brooks was still here. She was a former U.S. attorney. One of the weaknesses has been the penalties, the criminal penalties. Do you agree?
We can always, we can strengthen our penalties.
Okay. And Dr. Agarwal, does CMS need specific direction to require all plan sponsors to report all fraud information rather than keeping it strictly voluntary?
Sure. So as I'd mentioned earlier, we are working to evolve the reporting that's both given to plan sponsors as well as what they give back to us. We have started by focusing on leads, investigative leads for plan sponsors to develop and then take any necessary administrative actions on. We implemented an IT system called Plato earlier this year for them to be able to report that information
My time has run out. Could you just say yes, that would be helpful if it was mandatory rather than voluntary?
I think it could be helpful to help, to continue to evolve the program and evolve the relationship between the agency and plan sponsors.
Thank you.
Gentleman yields back. Now, Mr. Collins of New York.
Oh, thank you, Mr. Chairman, and I want to thank my fellow committee members for the line of questioning we've had today. So we had an interesting discussion, Dr. Agrawal, last time, if you remember, on Six Sigma, Lean Six Sigma.
Yeah, I don't totally remember it as a discussion, but we had that conversation, I guess.
All right, so let me pick up. After that meeting, what did you think, do, or say when you went back to your office? What did you think, do, or say when you went home that night? And did you take anything positive out of that discussion, or whatever you want to call it?
I think where there are ideas that benefit the program that we can implement differently to improve the integrity of Medicaid, of Part D and Medicare, whatever the case may be, we take that input seriously, whether it comes from the committee, the OIG, the GAO, or others. So again, we take good ideas seriously and we work to implement them. It may not be instantaneous or overnight, but the work is constant.
So afterwards, did you give any more thought to your 6.7% five-star error rate that you would, if you were at the FAA, allow 10 airplanes a week to crash and give yourself 5 gold stars? Or did you understand the tone of any of that, and did you take any of that back to say, oh my God, a 6.7 fraud rate is not only not acceptable, it's certainly not a bell ringer to say you did a good job?
Yeah, again, as I think we had communicated in that last discussion, we're not tone deaf, and we understand that there is work to be done. I look at that error rate and, recognize that it needs to come down. Nothing about that line of questioning sort of augmented or changed the recognition.
Did you change your 6.7 to something lower, or is your error rate this year still 6.7?
Yeah, sir, that's measured on an annual basis. It's not going to change day to day.
You see, it's being a private sector guy, well, if I was your boss, how long do you think you'd work for me?
Sir, I have certain misgivings about thinking about working for you.
As you should. As you should.
Let me be clear about something, perhaps. So, I came to this job just over a year ago.
That was funny, by the way.
Yeah. Thank you. Appreciate it. Look, I appreciate the message that you're trying to send, and I appreciate the tone of the sort of last line of questioning last time. I think what I should have said then in response to what I say to you now is, I came to this job from the private sector. I've been a clinician. I've taken care of thousands of Medicare and Medicaid beneficiaries. My purpose in coming here was to help ameliorate, make progress on exactly these kinds of issues. I think what would be helpful is a collaborative approach. If we can do that, if we can work together on devising solutions and getting them implemented, nothing would make me happier. I think merely pointing out that there is an error rate and kind of harping on it over and over doesn't help necessarily make that progress.
So, I mean, if you looked into Six Sigma, Lean Six Sigma, as the county executive of the largest upstate county in New York that was effectively bankrupt when I took over, we took that county from number 62 to number 1 in 3 years. 3 years after, I had 500 certified yellow belts, green belts, black belts, master black belts. My deputy county executive was a master black belt. We had so much money in our county 3 years in, we were paying cash for capital projects. We paid down $150 million of our county debt. We had a $100 million county surplus in 3 years. Lean Six Sigma works, but it starts with somebody at the top, in my case, the CEO of a county, but also it could be the head of quality control, the head of manufacturing, who comes in and says, I don't want to accept 67,000 errors per million opportunities. I want 0. And I'm going to measure that every day, and I'm going to chart that every day. And you know what? I'm going to send myself and I'm going to send others to schools, to training, to find out how to process map and error. What Dr. Burgess pointed out, and I got one of these phone calls the other day too. I got one from American Express. There was a $25 innocuous charge. They said, this looks like could be fraud. And it turns out it was. That was 15 minutes after somebody put through that transaction. That's an organization that gets it. That's an organization that says we won't accept any errors, let alone 67,000. So I guess as my time runs out, I would simply challenge you to dig into Lean Six Sigma more. It does work. It can be implemented in government, but it starts with the person in charge, someone like yourself, saying, I just categorically reject the level of fraud or other errors, and I'm going to be proactive in finding out how to do it better, and I would just perhaps challenge you to look into this a little further. With that, I yield back.
Chairman yields back. Now recognize Ms. Clark for 5 minutes.
Thank you, Mr. Chairman, and I thank our ranking member. I thank our witnesses. This is a very complex issue. There's no doubt about that. But the stakes are very high with respect to what is happening to the American people and the illicit prescription drug proliferation that's taking place in many parts of our nation. Ms. Maxwell, I think we all agree on the importance of ensuring drugs are prescribed and dispensed appropriately and legitimately. The Office of Inspector General's report suggests several ways to strengthen Part D program integrity efforts. The report recommends that CMS determine the effectiveness of programs and take action to ensure that sponsors' compliance plans meet CMS requirements. So, Ms. Maxwell, what more could be done to ensure that sponsors' fraud detection efforts are effective?
Our recommendations point to mandating the reporting of fraud and abuse that sponsors identify, as well as mandating the reporting of what sponsors do with that. We believe that comprehensive reporting from all plans would allow CMS the visibility and the tools to be able to assess the effectiveness of what's happening at the sponsor level.
So that sounds like a logistical challenge, right? You have several sponsors. Right now, they voluntarily make that information available. Can you drill down a little bit deeper in terms of systems that could be established that either trigger some sort of an action on the part of CMS, or, what would you suggest? Because if it's voluntary, they're operating businesses, they're sponsors. How do you hold them accountable in the course of the time that they're spending doing all the other activities that they need to do to run their companies?
Sure, and there are, because they are required right now to report voluntarily, I would assume, and I would defer to Dr. Agarwal for the specifics, I would assume that there are processes for that reporting to happen. So the systems are in place. The question is, why isn't everyone using them? So when we look for the voluntary reporting, we only see 35%. So the other plans have the capacity, they've just opted not to do the reporting.
So, Dr. Agrawal, is it an issue of, at this stage, voluntary just does not work and that it has to be a mandate?
Well, so to answer your question, we have been working to enhance systems that allow plans to report data back to us. We implemented a major enhancement earlier this year that allows that data to not only be reported but also be kind of searchable so that it can be utilized. What we have been doing is focusing on getting these plan sponsors better data about leads that they should be investigating and potentially taking action on. I think as we further that relationship, as we give them more data, we will be very interested in hearing back from them and perhaps in a mandate exactly what work that they have done. But we find that just by improving the system and improving the collaboration, we get better reporting.
So baked into what you're saying is that there was an assumption that there was some misgivings or misunderstanding of what exactly the sponsors were to do to report voluntarily? Is that sort of where the thinking is?
Well, I think that sponsors, like many private companies, have concerns about reporting data back, especially when it would be visible to other, potentially visible to other plan sponsors. So one way that we've worked with them, not just on the system enhancement side and making the process easier, is we actually allow them to report certain information de-identified of source. So they tell us a problematic pharmacy or a problematic prescriber, what they've done to take action against that entity or individual, but it's not necessarily clear to us which sponsor, or it can be sort of de-identified which sponsor put that in. From a private sector kind of competitive standpoint, that input made sense to us, and so we have taken as a step allowing them to input that kind of data so that we get better reporting about the actual problem, which is the fraud and abuse in the program.
So that can be a double-edged sword, right? They don't want the information attributed to them on the basis of some sort of a proprietary disadvantage. Is that what you're saying?
Well, I think, there is a narrative that, fraud and abuse just doesn't occur in the private sector. We've heard numerous committees kind of, suggest that that's the case. I think, you have programs like Part D, which is conducted through the private sector, and yet we see these problems. So, I think what we have to do is get to a place where we are really doing the best we can to get all the right information from plans. As we develop that expertise, we can, implement more stringent guidance, perhaps getting to the kind of mandate that OIG is requesting of us. But we're taking steps along that kind of evolutionary pathway.
Let me ask Dr. Agarwal. There's some troubling findings that the GAO report was reported in 2014. CMS conducted audits of Part D plan sponsors in 2013. Of the plans the agency audited, there were fraud, waste, and abuse findings in nearly all of the audits, 94%. Specifically, CMS found inadequacies in plan sponsors' compliance training, resolution of fraud, waste, and abuse inquiries in a timely manner, and corrective actions taken in response to potential fraud, waste, and abuse. These are troubling findings, and I think it goes to my previous question. How does CMS evaluate the effectiveness of sponsors' compliance programs? Have these efforts changed recently, and what is CMS doing to follow up with the audited plans to ensure that these deficiencies are being remedied?
Yeah, thank you for the question. So we do conduct audits of compliance audits of plan sponsors to make sure that they are compliant with our regulations, not only on the fraud, waste, and abuse side, but also obviously inclusive of their program integrity work. Recently, we have stepped up the amount of both the volume of audits that we do, as well as the focus in making sure that program integrity is part of those audits. Where there's a deficiency identified, we work with them like we would any other contractor, which is we can send letters of concern, we can place them on corrective action plans. There's an array of tools to get contractors into compliance with our expectations and stated requirements.
Dr. Agarwal, I didn't realize it was so far over time. If you could send us something in writing that outlines that would be helpful.
Thank you. Mr. McKinley. Thank you. Mr. McKinley is recognized for 2 minutes.
Thank you, Mr. Chairman. Again, I apologize. They had to slip down. We got a pipeline safety issue downstairs in another committee, and we just had a fire in a pipeline last week, and I needed to be there for that. But back on in this panel, a few months ago, we had a discussion here about one of the big problems here with opiates was overprescription, and I don't know that we came up with a solution how we're going to address that. Because I don't think we want Congress to be practicing medicine. But then we got into a discussion, I think it was with you, Doc, and that was over getting the prescription database in real time across the country to be able to have that so that we might be able to track the abuse that's happening that way. Are we making any progress on that from either one of you? Can you address that issue?
The Inspector General has not done any work. You're talking about the prescription drug monitoring databases in the states, I take it.
Yeah, in state they have, it's not in real time, it's within a week they'll file the information, but the problem of abuse is because it's in real time. Someone goes across the river into Ohio or West Virginia or Kentucky and they're abusing the system. We've been talking about that, my goodness, for at least 3 years. I'm just curious what progress we're making on that. We heard from the Attorney Generals, we're all suggesting that's one of the best ways we could make progress in abuse within our Part D. I haven't heard what progress we're making.
Yeah, so the implementation of PDMP, prescription drug monitoring programs like the systems that you're describing are, as you know, state-level initiatives. HHS has been involved in...
They can only do it statewide. I'm talking about interstate, and that's where the catch comes into it, because so many of us are in border states that we can cross easily over to where our population is generally on a border. So help me out a little bit about where we're going from the federal. Is there a role for us to play? Because you mentioned earlier, Doc, you said we need a collaborative effort. I'm looking to see what do we need from us to help out to make this collaborative effort.
Yeah, that's a good question. So I think I'd have to take that back in terms of, you know, the kind of interoperability issue that you're identifying or getting more states on board, because as I mentioned, that is being done at the HHS level. There's less of a direct kind of CMS role in that set of activities. I'm happy to take that back. I will tell you from just sort of my experience as a clinician, you know, one way that states, you know, try to remedy this issue, and you see this sort of in the D.C., Maryland, Virginia area, is by encouraging providers to get access to numerous different databases. Now, it's not a perfect approach, but I will tell you I've utilized that approach in my own practice just to make sure that, you know, patient or beneficiary is not crossing state lines to get, to kind of game the system and get these medications.
All right. I have less than 2 minutes. I just, let me go back to another statement you made back to the congressman from New York. You said we need to have more collaborative effort. What did you mean by that? Is there something we're not doing? Because our whole role here is to try to be supportive. So are we not being collaborative?
No, and you know, I appreciate the question. The comment wasn't really about the committee as a whole or anything like that. I think it's, from my perspective, a certain tone of kind of questioning that I find to be less constructive. But it was not about the committee in general. In fact, I think there have been ideas exchanged in recent hearings, and certainly even today, that I think do demonstrate that kind of collaboration.
In the last minute that I have, I remember the issue was over the 6.7%, but where do we think, I'm just curious, where should it be? If not 6.7, should it be 3, 2? Where do you, and is that the goal? Are we making progress, or have we plateaued at 6.7, or has it risen to 6.7? I don't know the trends, so I'm just curious. What can you share with us about the level of abuse?
Sure. So if you look year on year, there's variability in the number, and I think there's two things that I think really have greatest impact on the number. One is what are the requirements that we are implementing that either might be new requirements or that we're working to enforce more closely. What we find from a program integrity standpoint is that when there are new requirements or our enforcement steps up, inherently the error rate tends to rise because even legitimate providers are not able to keep up with those changes. So it takes a period of education to actually get everybody into compliance that then allows the trend to come back down.
Or is the trend going down?
I don't have the figures in front of me. I mean, there's year-on-year change, but we can get that to you.
Back to us, like,
sure.
Let's just say over the last 15 years, is the trend of is it increasing or decreasing?
We can go back as far as the error rate has been measured, but we'll share that with you.
Thank you very
Absolutely.
much. I yield back my time.
I think we all our members have spoken here. There's a few things I want to just wrap up with. Oh, I'm sorry, Mr. Griffith showed. Oh, Mr. Griffith.
Came in.
Oh, Mr. Bilirakis came in too. Then we'll go with Mr. Griffith for 5 minutes. I'm sorry.
That's all right. Thank you, Mr. Chairman.
Snuck in on me.
Mr. Chairman, first I would ask unanimous consent to insert into the record a statement from the National Community Pharmacists Association.
Without objection.
Let me go to Mr. McKinley's question real quick, and I understand that, you know, maybe in Maryland, D.C., and Virginia you can check that, but there are some real difficulties. From my district, if you count the Commonwealth of Virginia, you can actually, if you work it out really well, you could hit 5 states in a single day. So I do think we need to be looking at some way that doctors can check, because you get down there in that little corner of Virginia and you're touching West Virginia, Kentucky, Tennessee, and North Carolina all within a matter of 45 minutes to an hour. So you'd have to work it. You'd have to be at the doorstep of somebody first thing in the morning, but you could hit 5 states in a single day. So I would ask you to take a look at what Mr. McKinley raised. Now, my question also is about the methodology used in the OIG report on questionable billing practices. We all want to stop these things. We want folks from abusing the opioids, et cetera. As the 5 factors used seemed cut and dry without much room for additional consideration, my concern is that these results could present a broad generalization about pharmacies which may not paint the whole picture. For example, as I've just described to you, I represent a fairly rural area, and that area has a higher percentage of senior citizens than the nation as a whole. So a pharmacy might dispense a higher percentage of pain relievers when compared to other pharmacies in a different geographic or demographic area, simply because there are not as many pharmacies around, and perhaps the other pharmacies have a younger population that they serve. Also, it would not be unreasonable to expect them to have a higher dispensation of volume of controlled substances from a pharmacy located near a hospital or a surgery center or an oncology center. There are also pharmacies who are contracted providers for long-term care facilities and hospices. So how does CMS plan to address the results from the study to truly target the bad actors that we all want to get to without hitting the good guys who are just trying to serve their customers? And this came up earlier as a part of a complaint, because one of my rural pharmacies has one supplier for their medicines, and at one point they got cut off, and so they were having to tell their customers, yeah, I can't fill it today, come back at the end of the week when we change months. Well, that's hard if you're a senior citizen. You need that pain medication. And in fact, a friend of mine's wife was told that, who had just gone through some surgery. She had to wait 3 days. They managed, but that's really not the way it ought to work, whether you be in the urban areas in the northern part of Virginia, Maryland, and D.C., or whether you're in southwest Virginia in the rural areas. How do we fix it?
Yeah, I think that's you make a good point. You know, this kind of data analysis is a starting point. And, you know, I think as to the specific methodology, I'll defer a bit to the OIG. Data analysis is always the beginning point of our investigations. Now, I had shared earlier that on a quarterly basis, we send lists of concerning or high-risk pharmacies to Part D plan sponsors. Our methodology takes 16 variables into account, and in order for a pharmacy to make it onto the list, they have to be a statistical outlier in at least 4 of the variables. So the purpose there is to do exactly what you're describing, which is try to bring a little bit more specificity to the methodology. But again, after that follows the investigation. I think it's really challenging unless the data is extremely cut and dry, which occurs in rare situations, to take administrative action without the ensuing investigation in between. That's where we really try to get to the bottom of, is something really bad happening here, or is this just an outlier, but it's explained by certain geographic factors that you've identified?
All right, I appreciate it very much. Appreciate you all being here today. I apologize. I, too, we've got pipeline issues as well, as you might imagine, and I was in the other hearing. Mr. Chairman, I appreciate your time, and I yield back.
Gentleman yields back. Now recognize Mr. Belarakis from the full committee for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. Thanks for holding the hearing, and thanks for allowing me to participate today. Medicare Part D has been an important addition to the Medicare program, one of the most successful programs, I think, in the history of the Congress. It's a program that my constituents love and something Congress should be proud of. However, I've been concerned about the growing prescription drug problem in the U.S. and within the Medicare program. That's why in 2013, myself and our colleague Ben Ray Lujan first introduced the Medicare Part D Patient Safety and Drug Abuse Prevention Act, which would create a drug management program to prevent physician shopping and pharmacy shopping within the Medicare program. I'm proud that we were able to include it in the 21st Century Cures Bill that we passed last week. It's important. It's an important tool to the Medicare program to bring a common sense provision that has been used in Medicaid, TRICARE, and commercial insurance. It also makes reforms to the MEDIC program in keeping with some of the OIG recommendations. That's the 21st Century Cures Bill. It makes those reforms. The first question is for Ms. Maxwell. In your testimony, you talk about the need for a lock-in program in Medicare Part D to deal with prescription drug abuse and the problem of drug diversion. Do you have any estimate on the size of the problem, how many people and how much money are being lost to prescription drug abuse?
I don't have those specific figures, but I do have the figures in our data brief that the growth in prescribing opioids has been significant. It's been a 156% increase since the beginning of the program, which outpaces the growth in the general program. And so it's a continuing concern. We also have seen a tremendous increase in complaints against Part D, so we have significant concerns about this. We do, as a result, recommend the lock-in, as you mentioned, and I think as we've been talking about different ways to deal with doctor shopping, which can result either in patient harm or the diversion of opioids into the street, one way would be the PDMP to provide access to data around this issue and across state lines. But another way is this lock-in. I mean, it's specifically directed at that issue.
Very good. Thank you. Dr. Agarwal, I'm sorry if I mispronounced. I just got here. In 2014, CMS issued rules for Part D and stated that they had the authority to remove abusive prescribers from the Medicare program. Can you give me an update on this? How many abusive prescribers have been identified in the Medicare program, and how many prescribers have been removed from the Medicare program?
Sure. So, yes, this is part of our overall approach to extending our enrollment requirements into Part D. So what we've been working on is getting prescribers enrolled. I think I mentioned earlier that there's 400,000 prescribers that have written prescriptions in Part D that we are working to enroll. We are also working to develop exactly the kind of cases that you're identifying. So through proactive data analysis, kind of starting to tee up these cases for the first time. I'm not sure that we've conducted a specific revocation action using only that authority yet. Usually we try to do them in combination, and we may have added that authority to kind of another revocation action. But I can look into whether there's a case that we uniquely utilize that authority.
Thank you. One more question, Mr. Chairman. Ms. Maxwell and Dr. Agarwal, when the medics investigate a case and finish their investigation, I'm assuming that it's automatically referred to DOJ. Is that the case?
I believe they do make referrals. That's part of their requirements.
Okay. If DOJ chooses not to pursue the case, maybe because the view of the fraud is too small to be worth the time, does the information get automatically referred to state and local agencies or state licensing authorities? Can you answer that question?
I'm not aware of that specific mechanism. I do know that we are concerned when law enforcement action doesn't take place, that there are no mechanisms and processes to refer it for recovery of the inappropriate payments.
How about, are the Part D plan sponsors provided updates by the medics? How does the medic work with local authorities and state licensing agencies?
Again, I'm not familiar with the specifics. Perhaps Dr. Agarwal is.
Doctor.
Sure. So the medic, I think this was in the testimony, the medic provided 2,300 referrals to law enforcement over the last, I think it is 5 years. Obviously, we try to refer as much over to law enforcement as we can that we think kind of meets the threshold for law enforcement activity and investigation. Where law enforcement doesn't accept a case, we have a few options. We have shared information with state medical boards to try to get action on their part. We regularly share information with Part D plan sponsors. We do that on a routine basis as well as an ad hoc basis if new issues come up or there are new entities or individuals that become concerning. I think the threshold of our authority currently, there is the, OIG recommendation around recovery of dollars that Ms. Maxwell discussed. I think there are certain limits in our authority that prevent us from going directly to, say, a pharmacy and requesting recovery of those dollars. We do have to work through Part D plans, but there are a variety of avenues to do just that.
Very good. Thank you. Thank you, Doctor. Thank you, Ms. Maxwell. Appreciate it, Mr. Chairman. Appreciate it, and I yield back.
Thank you. The gentleman yields back. I do want to follow up. The committee sent a letter to CMS seeking information about the improper payment rate, and that response is due tomorrow. Will the committee receive that response tomorrow?
We have been working diligently on it. I think you will get the response tomorrow.
Thank you. By the way, you seem to suggest something earlier that the AC is causing an improper payment rate to rise. Did we misunderstand that?
No, I don't know if this was perhaps your line of questioning. No, what I'd said is that in the program integrity world, what we see often is that the improper payment rate rises when there are new stringent requirements that providers must meet, whether that's documentation requirements, enrollment requirements, or other. So, for example, the 6.7 rate that we discussed last time in Medicaid is largely driven by providers needing to enroll in Medicaid programs and states having adequate resources and systems to conduct that enrollment activity. I don't think anybody doubts the importance of enrollment. We talked about that as one of the major levers that we are now implementing in Part D that I think will be quite useful. We've already seen its impact in the rest of Medicare. But like any other requirement or standard, it can be hard for providers to keep up, and that can sometimes result in the improper payment rate going up.
All right. Well, we want you to continue to stay on that. Ms. Maxwell, thank you so much. We do appreciate all that your offices do. It means a lot to this committee. Next time we see you, Dr. Agarwal, we hope you're giving us a report that all those have been put into place. As you know, some have been sitting around for nearly 10 years, and that's just not acceptable. So we thank you. Now, let me get to my In conclusion, thank all the witnesses and members who participated in today's hearing. I remind members they have 10 business days to submit questions for the record. We'll have a number of those and ask the witnesses agree to respond promptly to the questions. And with that, this committee is adjourned.